Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 38 of the OBGYN podcast. I have something interesting for you all today, but before I get into that, I have a couple of housekeeping items. After the last episode, we have had a number of people sign up for the Slack, which is very exciting to me. And remember that if you want in, all you have to do is follow the link in the show notes or go to obgyn.fm and follow the link from there. That link will send you to the Slack website where you can sign up and download the application and get started talking to your colleagues around the world. The second thing I want to bring up today is also about the website, and that is every week I find material that doesn't quite make it into an episode. So instead of getting rid of it all, I decided to keep it and make a blog out of it, which I put on the website. Now, I try to throw in a little commentary as well as the link so you can go and read it yourself. So if you're at all interested in OBGYN news, then please check it out on a regular basis. There's going to be content there that you can really sink your teeth into, I hope. Now, with that out of the way, let me tell you what I have in store for you all. I've been working on my Anuplay episodes for a while, and I really wanted to talk to someone who's at the forefront of that push towards genetic screening in the late 70s and early 80s. Now, thankfully, I didn't have to look very hard for that because my mentor from residency was one of those people. His name is Gerald Quirk. He's an MFM at Stony Brook, and he started out one of the first, if not the first, statewide screening programs for AFP. His story of how that came together is extremely interesting to me because it highlights the collaborative nature of these large-scale projects and really demonstrates how most of what we deem to be success is really just someone putting one foot in front of the other after the other for long enough that it gets noticed. But enough about me here and what I think. I'm going to let Dr. Quirk tell you the story. I will say that the audio is a little rough in some places, and you can blame me for that because I'm still trying to figure out the technical part of this gig. But I don't think it's too distracting, and I hope the content is enough for you all to forgive me about it. So without further ado, let's get started with episode 38.
My name is Gerald Quirk. I am a professor of obstetrics and gynecology at Stony Brook University Medical Center, and I am the program director for the Fellowship in Maternal Fetal Medicine.
Right, and where did you get your training?
I'm the product of an MD PhD program at State University of New York Downstate Medical Center. Thereafter, I did my residency in obstetrics and gynecology at Columbia Presbyterian Medical Center in New York City. After completion of that residency program, I did a fellowship in maternal fetal medicine at University of Texas Southwestern Medical School / Parkland Memorial Hospital in Dallas, Texas.
All right. And then the reason we're talking today is because you implemented either the first or one of the first statewide genetic screenings done in the United States, and you did that at Arkansas, correct?
That's correct.
And so tell me about how you got into that. Where did the genesis of that program come from?
Realizing that was 30 years ago and your memory embellishes certain things and suppresses other things, I got sensitized to the fact that in Arkansas specifically, there was underutilization of perinatal services. Prenatal care was spotty. Access to care was spotty. There was a diversity of providers of perinatal care. Prenatal care, everything from lay midwives to board-certified obstetricians, gynecologists. And I had been charged by my chairman when I joined the faculty in Arkansas, amongst other things, to develop a statewide perinatal program. And I, just from reading the literature and knowing what the buzz was, I realized that serum screening with maternal serum alpha-fetoprotein was on the horizon. I didn't know if it was going to make a big splash, how important it was going to be, but I thought that I would like to engage myself in trying to develop a prenatal diagnosis program a la serum screening with AFP. Knowing also that the easiest part of that program is assaying blood for AFP, that there were other things that were much harder to do. Everything from, at that time, the FDA had removed restrictions and made it legal, if you will, to offer maternal serum screening with AFP for clinical purposes. It had not done that before. So before they did that, you would have to have gone through an IRB with a very defined goal for your screening. but there would have to be the understanding that it wouldn't be used for clinical diagnosis. Despite that, you had to have a FDA license to buy kits to do AFP screening, commercial kits. And I didn't have that license. I didn't have the desire to have that license, but there was a fellow on the campus in the Department of Pharmacology, of all places. His name was Ray Harbison, who had that license. So I approached him about developing a serum, setting up a laboratory to do AFP screening, and would he be willing to do the assays if we could find a source of funding to buy the kits to do the assays and for a tech to do them. And we had a lot of good conversations, and he signed on, so now we had a lab. The hard part was educating providers about what AFP was, how you use it, what the significance is. Then how do you collect the specimen? Can you drop it in a mailbox? Do you have to FedEx it? Well, there wasn't FedEx then, but do you have to do special mail overnight to get it to the laboratory? Can you get me the results back in an interpretable fashion so that I can use them? And those are all the really hard parts of putting this program together. Well, I got lucky in several ways over a short period of time. I'd gotten to Arkansas in 83, and in 84, the neonatologists and I, and the geneticists got a grant from the Public Health Service called a SPRANS grant. It's Special Projects of Regional and National Significance, and it was designed to develop a genetics program in the state of Arkansas, a statewide program. And the initial application that went in was with the pediatricians, and the focus was on genetic diseases in children and their families, so that you could counsel them about future reproductive activity. So when I came and got to know them, I started talking to them about prenatal diagnosis. And their lab was rather nervous about doing karyotypes on amniotic fluid specimens because their experience was with blood from children. So there was a woman by the name of Florence Char who was a very good pediatric geneticist. She was trained at Hopkins, and with a little arm twisting and a lot of cajoling and getting to know you, relationship building. We were able to get specimens of amniotic fluid that were collected for lung maturation, and she could satisfy herself that she could get a karyotype in a reasonable period of time. And then she would get cord blood from the baby and get karyotypes from the lymphocytes and see if it was the same kind of a karyotype. And that went very well. I might add, at that time, we used to draw about 8 cc's of amniotic fluid. People were afraid to get large volumes of amniotic fluid because they were concerned about fetal wastage. So we were working with 6 to 8 cc's of amniotic fluid. Also, the technology that we used in the laboratory to do to raise the cells was such that it took about 4 weeks to turn over a specimen.
Wow. A
karyotype specimen. And at that time, what you're seeing here is kind of a harmonic convergence of my interests and my willingness to develop relationships with people, but also the evolution of technologies. So the technology that developed was raising amniotic fluid cells on glass slides instead of inside of bottles, because if you did inside of bottles, then you had to trypsinize the bottles to get the cells. All right. So you just leave the cells on the slide and work with the cells on the slide. I am not expert at that. Dr. Char was. So we could turn around amniocentesis specimens in, we used to say 1 to 2 weeks, closer to 2. And that's kind of where we are today. It's like 8 days. So we had that piece in place. And then out of the blue came, a document from the American College of Obstetrics and Gynecology that was a medical liability alert concerning serum screening of AFP for neural tube defects. And it was not put out by the Committee on OB Practice or anyone like that. It came out from the legal department of ACOG. What their specific name is, I don't know. They just said that you need to be aware in your community what the availability of screening was, who did it, and blah, blah, blah.
Like standard of care in your community.
Yes. And of course, the standard of care in most communities was not to do it.
Right.
There were some places in the country that were doing it. Aubrey Molunsky, for one, had a program up in Eastern Massachusetts. He was out of, at that time, I believe, Tufts or BU. He'd been at both institutions. And there was a regional program out of Yale. And that was pretty much in the United States. That's pretty much what it was. There was much more screening in the UK, but they hopped the ball earlier because the incidence of neural tube defects, especially amongst the Irish and the Welsh, is much, much higher than it is in the United States by an order of magnitude. So I started getting calls from doctors around the state that I was just getting to know, asking me, what should we do? How can you help us? How can you help us? And for me, this was like perfect, because what I wanted to do was develop a maternal fetal medicine consultative practice with access to all the patients in the state through their providers. And here, all of a sudden, the providers were calling me up asking for help on this issue. So I spent quite a bit of time going around the state talking about a lot of maternal fetal issues and offering them help assistance with their complicated patients. And here's this program, and it's a pilot program, and it's sponsored by, it's funded through this SPRANS grant that we got from the Public Health Service. That grant will pay for a mailing tube, a red top tube with a red cell separator in it so that you can separate the red cells and other cells from the serum. It'll pay for a stamp on a container to mail it. And we will process the specimen. And a new technology that was introduced into medicine about that time was the fax machine. We went out and bought fax machines and gave them to the providers. And we did that as part of a bigger process, like we'll take a look at fetal heart rate tracings, we'll review records and see what you think. So we piggyback this on all those fax machines. So we can we'll hard copy you by mail, the result, but in the meantime, we'll fax you as soon as it comes out of the laboratory.
So what you're talking about there, those are the things that are interesting to me. So often in medicine, we get hung up on the technology. We get a new tool and we can do this assay with it. And now today it's even a little bit easier because we have these national laboratories, and you can send something to the bioreference lab in Utah and get some obscure tests get done. But the hard part in doing anything is the little details. Like, okay, I can do the test, but how do they get the patient blood to us? And okay, well, who's going to pay for the stamp? And how do we get the result back to you? And all those little things are the barriers to having people buy in and want to do it with you. Because if it make it hard for them, they won't do it.
Well, or if you tell them that they should be doing this, nobody wants to be told what they should be doing, So you're absolutely correct. I would say that especially in this day and age, we're beginning to really believe that medicine is science. And medicine is not science. Medicine is a social and human interaction embedded in a culture. And what we have done in the last couple of 100 years is elevate it so that it is scientifically based, as opposed to superstition or religion or just custom. And we fight with the custom part of it all the time.
I like that distinction, though, between science and scientific based. I like that.
Yeah, and I tell the residents this all the time because, the residents will have a whole sleeve of laboratory tests on a patient, and they've never bothered to do a careful differential diagnosis, So they're not using the laboratory to support or to refine their differential diagnosis. They're using the laboratory to create their differential diagnosis, and they are ignoring the physical findings, the history and physical. And then, of course, I have white hair now, so they think that I'm just a grumpy old man when I talk to them about that, but I believe that to be the truth. So it was, but this was a very exciting time because what it did for our program, of course, you can never separate your ego from all of this. I was asked to do this thing. I did this thing. The chancellor of the university always wondered why the senior clinical leadership of the medical center didn't have a better reputation, if you will, as a first-rate clinician providing first-rate services, and he was at wit's end to know how to do it. And then he knew what I was doing. He'd hear it on the street, and he would hear from the director of the Department of Health and from all these other people. So he thought that this was great. So this is good. I felt that I had accomplished something. One of the reasons that I left Dallas and went to Arkansas, I was having a wonderful time as a faculty member at Arkansas, both in the laboratory and in the clinical setting. And coming from New York, I had no shortage of self-confidence. And so I began to wonder, and I felt pretty good about myself professionally, but I began to wonder if I was as good as I thought I was because it was an intrinsic property of me, or if it was the people and the system that surrounds me. And that was the first time in my life that I actually thought about systems of care. And I thought about it from the very personal level of what makes me what I think I am. Mm-hmm. Is it something that God gave me, or is it something that I received from a larger community of brethren, mentors, and associates? And I decided I could never answer that myself unless I left this really good institution that I was the faculty member for. So one of the major attractors of me going to Arkansas was to test myself. Okay. Can I bite off something where I know I don't have expertise in a lot of areas, but to put together people and money and commitment and learn politics and, city boy in Little Rock, there's differences in cultures. And what could I accomplish? And since I felt I was the final arbiter of how good that was, I thought I did a pretty good job. But what we eventually had, because of that liability alert, all across the country, people suddenly got interested in AFP screening. And less than a year after that, it was first described that low AFP values were associated with trisomy 21. Well, now this was like this explosion. You could tell that you were at the birth, or at least involved in the gestation of what was going to be an explosion of prenatal diagnosis. And here we are. So the beat goes on. But it all started with serum screening for alpha-fetoprotein, ACOG's liability alert, for which they took a ton of heat in the journals of public health and in the New England Journal of Medicine. And they took a lot of heat. But interestingly, perhaps the fear of being sued for not doing something, I hate to say it, guys, now I sound like a plaintiff's attorney, perhaps the fear of being sued for something did something to improve the quality of care or the availability of screening for important testing. And there you go. By the time I left there, we were doing. I had a contract with the Department of Health, so we were the preferred provider for serum screening, and by that time we were doing triple analyte screening. I was doing 1,200 amniocentesis a year myself. People were coming from 200 miles away for the genetic counseling and everything that was involved in a genetics program. It's the one time in my life that I can say unequivocally we fulfilled all of the aims that we stated were the specific aims of that Sprans grant we got in 1983. And we made it self-sustainable. We didn't have to write other grants to continue the project. We had CMS in Arkansas saw the value to the service that we were offering. The Department of Health saw it. In Arkansas, as in a lot of the country, the counties and states in the middle part of the country, no matter how rural, every county seat has a health clinic, and in that health clinic are prenatal clinics. Mm-hmm. So I knew all of the people that were the directors of all of the prenatal clinics in all of the counties of Arkansas. Now, in New York, which is much more urban and much more affluent, 48% of the patients are Medicaid or self-pay. You can imagine in Arkansas what that number's like. It was a significant, I would say probably between self-pay and Medicaid, it was more like, 70%. So we had created an opportunity for, the state had already invested in prenatal clinics. We were providing state-of-the-art support for prenatal clinics, prenatal diagnosis. Mm-hmm. And I give my credit to the legislature of Arkansas to provide special funding for the project that we were doing. At one point, they gave us a 2-year grant of money of $500,000 to provide all of these services on a rates-based schedule to all of the patients who receive their care in the county clinics. So finally, I learned something else too. Never prejudge people. If you're from a rural state and have a twang to your voice and you speak kind of slowly, doesn't mean that you're undereducated or think slowly. These people all wanted to do the right thing, and given the opportunity to participate in something bigger that they decided, I never told anybody that it was the right thing, but they decided that it was the right thing and the best thing for an otherwise underserved group of individuals. They were on board with it. So that's probably, developing that program is probably the signal event in my life professionally.
So it sounds like with the state there and the population that was there, you had not only a willing but an invested partner. Because they were already spending, the resources, both in people and money, to take care of all these women to begin with, and they were doing a lot of it. So 70% is a large number.
Correct.
So they were naturally invested with what you were trying to do. Now, this is the mid to late 80s in Arkansas. If these women had a positive screen, what were their options?
Well, their options were to do nothing. Their option was, at that time, the standard of care was an amniocentesis because the screen was for a neural tube defect or a trisomy. So depending on whether it was the high or the low side. So if we learned, because of the way the clinical literature was evolving, that what was almost pathognomonic of a open spinal cord defect was, if you could look at the spine, obviously, and see the defect, it was a defect. But that's not always easy. And back then, the equipment wasn't as good. Pixels per square inch were lower. It was discovered that the lemon sign and the banana sign, the abnormalities of the internal anatomy of the brain and the calvarium are almost pathognomonic for neural tube defects. So we came to get away from doing amniocentesis in patients that had a normal appearing spine on ultrasound or a normal appearing calvarium and posterior cranial fossa. And that was good because when you look at risks and benefits, if you can screen something or exclude a diagnosis without doing an invasive procedure, then you're doing a good job. So we did away with that. But then what emerged was still the other side that we didn't even think of or know about in the beginning, which was screening for trisomy. So that was all based on amniocentesis.
I can imagine probably, again, you guys were the big referral center for the state. If a woman elected for a termination, you guys are probably doing that at the university there.
We were, and of course that's a whole other issue for another day, because access to pregnancy termination is a hot button issue today as it was 25, 30 years ago. It's evolved a little bit, but not a whole lot. So, but yes, we were the group of people. Though I will say that we had some marvelous colleagues in the community who had practices that were very heavily committed to providing abortion and family planning services. And these were guys in private practice over and above whatever family planning could do. And if we were really in a bind, they were always there to help us. Always. So that was very nice.
So it sounds like almost that you wanted to build this perinatal referral program, and you used this AFP and with a confluence of lucky events as like a Trojan horse to build this network because you wanted to build a network above and beyond AFP screening, but it sounds like that was kind of your door to building this.
Yes, and I'm really only talking about like chapter 1 and 2 of what we did in Arkansas. And we subsequently, there was a coalition put together that our program was a part of, the Children's Hospital was a part of, the Department of Health was part of, and Department of Financial Services, which is people that run Medicaid. And they all came together and defined some things that we ought to be doing for pregnant women. And we were quite successful in what we wanted to do. And it happened. And again, so much of it is the Prince of Serendips, the guy that sends his 3 sons out, gives them clues, and they don't know what they're looking for, but they chase down the clues. And one of the 3 who was thought to be the least intellectual came back and identified a creature, and he could draw the picture of the creature. And the father of these princes was impressed because what he drew was a camel, and that's what it was that he wanted them to discover. So there's a lot of chance. You follow something, you pursue it, and then you find something else. And, you never want to get too much mission creep, but you want to keep to your core mission. And our core mission when I got there was to improve perinatal services for pregnant women. And we kind of by coincidence and design and a moment in time started with prenatal diagnosis, serum AFP screening, and ultrasound, and grew it from there. We got a reputation. People knew who we were. My kids, I was on TV a lot. My kids were afraid to go out on the street in Little Rock because they would all ask me about their father. Perhaps on another day we could talk about, we developed another program, it was Campaign for Healthy Babies, which was with this coalition of individuals and with the help of Hillary Clinton at the time that she was like the first lady for the state of Arkansas, and she was on the board of trustees of Walmart. And we developed something out of that. And there's the department now has a program that's called Angels, and I don't know everything that Angels is doing, but they're very deeply embedded. It's Curtis Lowry, who's the chairman there now. He's developed developing telemedicine, so people can get interactive consultation online. In OB, in gynecology. It's wonderful. But that's all grown out of the reputation that the department developed gradually and over a period of years, over 30 years ago.
That's funny. I've been talking a lot recently about, it's easy to go look at a successful program and you want to go and say, well, how can I make that kind of program where I am? And we do this. Systems people, hospital people do this a lot. You have the successful ER program or whatever it is. How can I go build that where I am? And you go there and you look at it and you try to find what their secret sauce is, so you can do that at your own place. And really what the secret sauce is 20 years of experience and building the relationships and doing it step by step. There is no shortcut to building a program like that. You have to start with nothing, get lucky, have the right people, include people, and then 30 years later you have a program everyone's coming to look at it and say this is fantastic.
Yeah, chance and a prepared mind and patience.
The last thing I want to ask you about is, so I'm assuming that you were doing a full clinical load at the same time that you were building this program. Now, obviously, you're a little bit crazy because you're an MD PhD, so that already puts you in that category. But it sounds like you spent a lot of time, especially if you're traveling all over Arkansas to meet with people. So, how many hours a week do you think that you were working when you were building this program?
The honest answer to that is I have no idea because I didn't really think of it as work. It was just what I did. Sure. So, but I can tell you that I made a commitment and I had the okay from my chairman to go on the road 1 day a week. Okay. I would take a research nurse and sometimes I'd take a lab person or somebody else. And we would talk to anybody that wanted to talk to us. We'd call them up and say, hey, we're making a tour. Is there anything that you would like to hear from us about what it is we're doing? And they always would respond. So we never came with we're going to have a lecture. We're going to do it in your hospital on this date. We never did that. We would say, what do you want to hear? A true needs assessment in the best sense of the word. What do you think you need? And then when you get to know them and they see the value to I've got a question, how can you respond to it? When they begin to see the value to that, then they come to you and they say, hey, there must be some things that we could be doing better that we haven't recognized. What do you think we need to know? And that's the best part, because now you know that they have confidence in you. You have a real relationship with these people. You're talking at the same level. And now you can put out a curriculum and say, well, we've got this stuff. Would you be interested in this? Oh, yeah. So, that's really the fun. And that's when you create a culture.
And that, I think, one of the things, you and I go back, 10 years now. And so, how my brain works and I know how your brain works, but we're both very into systems. And that's why I wanted to have this conversation with you, because building something like that is so outside the scope of what we consider to be medicine. And it encompasses so many other things that is very systems-based, that I think that as modern medicine and we become more and more codependent with hospital systems and with just other providers as medicine evolves, and now it's not OB anymore. Now it's OB and some medicine, sometimes radiology, sometimes urology, whatever it may be. You're not working by yourself anymore. And so how do we put this all together into a system that makes the best care for our women? And I think we're constantly challenged with that now, whereas I think 30 years ago, that was maybe not so much the case, although it's always been kind of the case. So I really wanted to get your insight into how you did it. And it sounds like you did it as we would expect, with hard work, being a little charismatic, getting people to want to work with you, aligning interests. So finding people who want to do something that even if it's not directly what you want to do, something that is similar, and you're pointing in the same direction. So you were talking about the karyotypes and the amniocentesis, which is certainly part of the AFP screening. And finding those people and then just maybe getting a little lucky. And really, at the end of the day, putting one foot in front of the other until you have what you're looking for.
So one final thing about that, too, that's interesting, what people's interests are and what you need. Back then and even now, it's really hard to get formally trained genetics counselors on your staff. And you don't want too many of them because you can't bill independently for what they do because CMS doesn't recognize them as licensed independent practitioners. So you walk this fine line all the time of what do I need, what can I get, if you will, and what can I afford. And one of the things for sure when I was in Arkansas, I had one genetic counselor. And I said, well, we got to the point where I needed 3 or 4 just to do all these counseling visits for to support our AFP screening program, right? I had, at one point had 5 or 6 counselors. So what I did was I go, there's a lot of people here in this institution and in the community that I got to know that were nurses, were social workers, and they had a really They had an interest in what we were doing, no expertise, but they believed in the value of what we were doing and wanted to support it in some way. And I said, well, and they were good with patients, or clients as they call them now. And I go, well, how about if we could train you, teach you, educate you? I don't have a certificate. This is, on-the-job training. We'll train you how to be a counselor. And so this one genetic counselor that I had very quickly came to be the person that didn't do all the counseling. She was doing the education of the people who could do the counseling, as teaching the teachers. And that was amazing because I found that the things that we needed to communicate to the patients and the dialogue that you wanted to have with the patients were pretty easy for bright people to lead, if you will. The hard part was identifying people who had the social skills to talk to all manner of people that come walking in the door. And so we got those people on very strong reference addressing human skills. That worked out. So I wasn't going to let the shortage of genetics counselors hold us back. We're going to figure out another way to do good genetic counseling. And so we took non-genetic professionals and made them counselors. Yeah, it was good. It was good.
So also, you combine the last thing, which is, I hate to use this term because it's a little overplayed these days, but you think outside the box. How do I solve my problem in a way that isn't just, throw money at it?
Oh, that's right. The best thing is to forget that there's a box at all.
There you go. And so you find, and that's the other thing, smart people are smart people, right?
Yes.
So if you find smart people, you can basically teach them to do anything. I often say, being an obstetrician 95% of the time isn't that hard. I can teach most people to do a vaginal delivery or a C-section. We're there for the 5% of the times where it's not straightforward, which is why midwives should be doing more of our deliveries, right? Because they're excellent and, most of them are uncomplicated.
Right.
That's a different discussion for a different day. Well, I want to thank you for sitting down and talking to me. Is there any final statement, any final thoughts that you want to share with us?
Well, my final thought is if you have something you want to do, just go out and do it. I won't be so crass as to say that it's easier to get forgiveness than permission, but I think you have to be willing to get into a little bit of trouble once in a while. I mean, not legal trouble, but stretch yourself where someone has to pull you back. Don't be afraid of that. And finally, this is the first time that I've actually sat down and reflected upon developing this program in Arkansas. And I want to thank you for the opportunity of making me sit down and think about that and share a little bit of it with you today.
Well, great. Thank you very much for being on the show.